The purpose behind adding bevacizumab, which is an anti-angiogenic agent, to immune therapy is in the same way that chemotherapy may modulate the immune system. There is data for anti-angiogenic therapy with a monoclonal antibody to VEGF for also modulating immune effector cells, which may then help the immune therapeutic do its job, so to speak, when administered in combination.
We recently had data from the IMpower150 study. This also focused on non-squamous patients. And here it was a bit of a more complicated study in that there were 3 different arms to the study, arms A, B, and C. The control group was arm C. This was carboplatin, paclitaxel, and bevacizumab. And this was compared against either carboplatin, paclitaxel, and bevacizumab plus atezolizumab, or carboplatin, paclitaxel, and atezolizumab, so removing the bevacizumab from that arm. At both AACR and ASCO, we saw data from this study, and it did look like the quadruplet regimen of carbo, paclitaxel, bev, and atezo resulted in improvements in both progression-free survival as well as overall survival compared to the control arm of carbo, paclitaxel, and bevacizumab. So overall, we have another positive study for patients with non-squamous histology. In my mind, I think the uptake of the IMpower150 regimen will probably be less than with the triplet pemetrexed containing regimen used in KEYNOTE-189. I think part of this has to do with and again, acknowledging cross-trial comparisons, but the KEYNOTE-189 data was quite impressive if one looks at the hazard ratios for survival. Also, in the United States, pemetrexed backbone is more commonly used due to its favorable safety profile. And so in my mind, despite having 2 positive studies, I generally employed platinum pemetrexed plus pembro for patients based upon KEYNOTE-189. One key distinction between KEYNOTE-189 and IMpower150 is that KEYNOTE-189 excluded patients with sensitizing EGFR mutations and ALK rearrangements. By contrast, those patients were allowed into IMpower150, provided they received the relevant targeted therapy. And it was a bit surprising to all of us to see that the benefits to adding atezolizumab to carbo, paclitaxel, and bevacizumab even extended to the EGFR and ALK positive subgroups compared to the control arm. The reason this was surprising is because in earlier studies of just using single agent checkpoint inhibitors, the benefits among EGFR and ALK positive patients were quite minimal among with just single agent checkpoint inhibitor. We saw response rates among EGFR patients were 10% or less, and in meta-analyses there was no improvement in survival compared to single agent docetaxel. And among ALK positive patients, really the response rates have been 0 in the limited studies to date. And so in IMpower150, we saw that now combining chemotherapy with VEGF inhibition and PD-L1 inhibition, it did look like there was an improvement in the EGFR and ALK positive patients. So this really represented the first study where we have an improvement with checkpoint inhibition in those molecular subgroups. And I think that's one of the key take-homes from the IMpower150 data.
I think we should be very careful when we look at new potential biomarkers. And in this trial, the investigators had looked at this T effector signature, where it seemed like there may be a signal for increased benefit in those that fell into the high T effector category. And we know that even when you look at PD-L1 and you look at tumor mutational burden, which one can argue are much more vetted in terms of biomarkers, that those biomarkers aren't perfect in their ability to predict the likelihood of response to immune therapy. I think that looking at this T effector signature is much more in its infancy compared to those other biomarkers. So it's something that I think we should continue to look at on an investigational level, but on a clinical level, I wouldn't yet jump to rely on this as a potential signature for giving this combination until we see further data come out.